Welcome to Healthy Conversations, sharing the knowledge, experience, stories, and the wisdom of herbalists and other natural healers, with your host, Stephen Horn. Today's guest, Chanchal Cabrera. Hi, welcome to another episode of Healthy Conversations, and I have with me again Chanchal Cabrera, a medical herbalist trained in England who's been practicing for 40 years, and what an awesome professional herbalist who has an outstanding career. And I have your book. I actually should have grabbed it, but you recently published a book on herbal therapy for cancer, and I'll put the description and the link below, so if people want to get a hold of the book and look at it, it's fantastic. We, in our previous discussion, talked about toxic botanicals, and that's one of the things that we often deal with in working with cancer. First of all, I would like your take, on, as an herbalist, on the whole idea of cancer therapy in general. What is
nothing like a big question to kick off with.
No, because I mean, obviously, there are people who go the natural route, there are people who go the medical route, there are people who go a hybrid route, whatever. Yeah. And cancer is a very scary thing for people, And so when you're making decisions about that, can you give people just a general guideline of what they should look for some people to work with if they're trying to deal with cancer?
Yeah, it's a great question. It is really scary, and notwithstanding the fact that somewhere between 1/3 and 1/2 of us are going to have this diagnosis in our lifetime, it is still a very scary situation. Those words are just like, people feel it's a death knell, although of course today that isn't always necessarily the same as it perhaps was in the past. Cancer treatment in the mainstream medical model has been archaic and barbaric for a very long time, and only maybe in the last 10 years or so it's beginning to open up now to looking at customizing and individualizing and targeting treatment. And this is very exciting and novel, of course, tied into breaking the genome so that we can understand the genetic component of cancer. But cancer is so much more than just genetics. So I teach a lot about cancer care now. Since my book came out, it's enabled me to get out in front of a lot of audiences. And I always start by saying, look, the conventional understanding of cancer and the simplistic understanding of cancer is there's DNA, it makes an error when it copies, and that error gets perpetuated, and that makes genes that are erroneous, and they form proteins, they code for proteins that don't do their job properly, and now you're away to the races, right? Based on DNA and genetics. Then that is true. It is absolutely true. The thing that kicks off cancer is a DNA mutation. But why? Why did that happen? And now we're talking about epigenetics. And epigenetics is all the things that influence which genes are operational or which are dormant. So if you're in an environment that promotes a certain set of genes, that so-called oncogenes or cancer-promoting genes, then they're the ones that will manifest and be functioning, and you'll end up with cancer. But if you're in an environment, a terrain, if you like, where you have more tumor suppressor genes being activated, then that changes the whole dynamic. You're less likely to get cancer. And if you do, because mutations do happen, mistakes are made, your body will be able to catch them and correct them or take out those erroneous cells, and you don't get cancer. So it's really actually, despite genetics being the kind of baseline in conventional care currently, what is really coming through now and will become more and more apparent as time goes on, I believe, is the metabolic component of cancer.
Yeah.
Metabolic meaning, how is your cell working? Not just your genes, but your whole cell. And if it's awry, if it's not working as it should, what can you do to change that? So it comes back, Stephen, it comes back to all the stuff we've always known, which is about terrain. It comes back to making sure that you're metabolically balanced, that your digestion, your food intake is the right intake for your physiology and your needs, which is not one size fits all. It's all kinds of different diet permutations.
I love it when someone says that, because it shows because there's no one diet that fits everybody.
And then it's about your digestive function. And your elimination function, which yes includes bowels, but it also includes your liver and your kidneys and even your skin. And how do you eliminate waste? Not just toxins from the environment, but your own metabolic waste. And and so all of that. So if somebody gets diagnosed with cancer, the first thing they need to do is nothing, or at least not to rush to make decisions that are irreversible and life-changing, because you don't know what you have. When you first get diagnosed, you've had that growing in you for at least 2 up to 5 years or longer. It's not something that happens overnight. You don't get cancer from one day to the next. It takes months, if not years, for it to even double in size, and then to get to a point where it's measurable enough, sizable enough to cause you a symptom that gets you a diagnosis. It's not new. So rushing diagnosis on Monday, start, surgery on Friday, chemo on a week later. No. You need to stop. Take a step back, take a deep breath, and start to put all your toolkit in place. Start to figure out what it is you want to do and how to do it. And then maybe a month, maybe 2 months down the road, you're into active, targeted, full-on treatment. You haven't done nothing in between. What you've been doing is getting to figure out, is cancer? What is my cancer? What do all these numbers on the page mean? How do I get the kind of blood work I should get? How do I interpret that blood work? Who's my team? Who's my team leader? Who's my support members? Yeah, and then looking at your diet, looking at your stress, all these foundational things. You haven't even talked about chemo yet. And then, of course, where I come in is thinking, well, okay, sometimes you need surgery, sometimes you need chemo, sometimes even radiation has a place. None of these are never, ever. Never say never. You do what's appropriate for the person in front of you in that moment. And sometimes if they have extreme pain of a tumor on the spine, radiation will sort it out. It won't fix the cancer, but it will get them out of extreme pain. So there's value to these things, but it's about how do you get the best value. So for example, with chemo, you need to know you have the right chemo that's going to target your cancer. There's a myriad tests for that now to figure out that this chemo is something you can activate in your body, that you can use and you can eliminate from your body. So that's the first thing. If you're going to do chemo, let's figure out which chemo. And then you start to think about how to do it best. Do I do fasting before the chemo? Do I do intermittent fasting all the time? What's about the timing of the chemo? When do I, morning, noon, or night? Does it matter? Actually, it does matter. There's all these different ways of making the conventional drugs work so much better for you. It shouldn't be one size fits all. Breast cancer, this is the set of drugs you're offered in this hospital system. If you go across country, it might be a different set, but no, you don't get to choose. It's one size fits all in our system, and there's no indication that that is going to work for that individual. So that's what's really exciting in cancer care now, is this ability to customize, and it'll only get more and more. This is a growing field. You talked about the sort of difficulties of, the patient having to choose, what am I doing? Should I do chemo? Should I do herbs? Actually, the answer really is we shouldn't be talking about alternative medicine, because alternative implies a choice, this or that, either or. And that's the worst thing, because the patient needs it all, but they need it in a manageable, integrated way. So in my book, I talk about this. I think it's really important to think about our language, in the way that we're trying in many, many ways now to decolonize herbal medicine or decolonize medicine altogether and have a more holistic worldview of medicine. Mm-hmm. If we talk about alternative, it implies the patient needs to choose one way or the other. That's not likely to work. If we talk about complementary, it's a little bit derogatory to people like you and I who sort of complement the doctors. It doesn't give us a lot of autonomy. And so for many years, I called my work integrated healthcare. I integrated herbal medicine. And I thought, oh, that's great. I can integrate all these different tools from all these different disciplines and practice medicine, but without providing drugs, all of that. So some years ago, I was talking to an ethnobotanist from the University of Montreal, and he had been working with Indigenous elders in northern Quebec in doing ethnobotany research into herbs that they were using for diabetes, but many of them were also on diabetes drugs. And he wanted to talk and write and research about the integration of the drugs and the natural traditional treatments. And they objected to the language integration. They said they didn't want their medicine being integrated because integration for them was loss of cultural identity, loss of indigenous knowledge, sort of homogenization. Integration wasn't what they wanted. They wanted to be unique and special within the system. So my ethnobotanist friend asked them, what is the right descriptor for the kind of work that we're doing here? And they said, collaborative medicine.
That's terrific.
That really rang with me. And this was probably almost 20 years ago now. I'm like, that's what I want to call my work. I want it to be collaborative. And that puts everybody in, ideally around the table. So yes, the oncologist, the radiologist, the nutritionist, the patient maybe is in there, the massage therapist who's supporting them through their lymphadenopathy, all of these things. So that's the goal, is integrated medicine. And that's kind of the job I do, is helping the patient navigate the treatment options to find the best fit, drugs, herbs, surgery, all of it.
I'm going to tell you my least favorite thing about the whole system around cancer is when the medical doctors tell people, you don't do these treatments, you're going to die. And then you have the natural people saying, you go the medical way, you're going to die. Yeah. And I always think, wait a minute, okay, this person is already scared and confused, okay? They need to make decisions. They do not need to have fear put as their motivating force. Because if someone believes that a treatment is harmful, like I believe that radiation is going to kill me, and you try to talk me into it, and you convince me to do it when I think it's harmful to me, the mind plays a huge role in getting better from something like that. Or the opposite, if you are a natural person and convince someone not to go get the surgery, and they believe if they don't get the surgery they're going to die. Again, we don't want to play those games with people. We want to try to help them figure out the approach that is reasonable and that they feel it has the best chance for it to work.
Absolutely,
because mindset is a key factor in this.
Yeah, well, we know that the placebo effect is about 30%. So, we at least 30% of all of our clinical success we can put down to the power of the mind. And the danger of that, of course, especially in the world of cancer treatment, is the flip side, is that the power of the mind is also, did that bring the cancer on? Was it my negative thinking? Was it my chronic depression? Was it my horrible husband? All of that stuff, right? So we have to be careful as clinicians to tap into that positive thinking and using, the power of the mind to heal the body, but also not kind of allowing that to taint the, how did I get to this place? The only value in looking back, how did I get to this diagnosis, is if it's going to change your lifestyle. If you're going to look back and say, well, I ate rubbish for years, maybe I should, stop going to the fast food joint and quit smoking. And
exactly.
So that's the value in looking back at past behaviors. And, I think one of the things that happens with this kind of diagnosis, it does give you an opportunity, if you like, to wake up and say, wow, okay, I haven't been happy. I haven't done well by my family. I haven't, whatever, like try to make reparations, I guess, to make yourself happier and more at peace so that you can then focus on healing. And this is we all should do that all the time, shouldn't we? Right. But it's sometimes a wake-up call for people to say, okay, if epigenetics is real, then how I feel and think does matter. And I need to work on finding ways to make that a positive experience.
Yeah. Well, I want to get into a little bit of some of the cytotoxic botanicals that you talk about in your book.
Yeah.
But I do want to mention, there are two things I routinely recommend to people who have been diagnosed with cancer. One is I recommend forgiveness therapy. To think of anybody that they may hold resentment, grudge, that they may have something inside that's eating them, and I give them exercises to go through and let go of all that, move on it. And the other one is I give them Dr. Paul Pearsall's pleasure prescription. And this has always been very revealing for me because the prescription is that you have to make a list of 10 things that are physically pleasurable for you. And you have to do one of them every day.
Wow.
And here's the thing. I can tell you almost 100%, the minute I say this to someone who has cancer, and I say 10 things that are physically pleasurable, their first thing is like what? That's the first thing they say, which suggests that they are not really in touch with what they need. And then I give, well, get a massage, get your foot rubbed, go take a walk in nature, listen to some beautiful music, something like that. And then they say, oh, and then do you want to know what their next thing is? I don't have time for that.
Oh, yes. Yeah.
And I say,
yeah. Do you have time to be sick?
yeah, exactly. And I have to, and I actually have to convince them that they need to spend time taking care of themselves.
I love that prescription, the pleasure prescription. I'm going to adopt that. I absolutely love that.
Yeah, and it's told me a lot about the mindset of people who get into that state. You have to learn to take care of yourself. You have to learn to let go of the past and move forward. Anyway, okay, so let's talk about some of the botanicals that are used like chemotherapy, because after all, a lot of chemotherapy drugs originated from plants.
Yes, they did.
Like Taxol from Pacific Yew.
Taxol. So let's talk about Taxol, because and the herb that it comes from. Super interesting. So Pacific Yew, Taxus brevifolia, from the Pacific Northwest, was the first place that the Taxol was identified. It is actually in other yew species as well, and other yew species are used now as the source material for the drug. The drug is semi-synthetic. The Taxol starts with a plant extract and then is manipulated in the lab into the drug. Partly for patenting, this is true, but also, to be honest, in the beginning, when this drug first came out, it took the bark of 3 mature Pacific yew trees to get enough Taxol for one person's treatment. And the Pacific yew is not a timber tree. It's not like the Irish yew or the European yew, which gets to be thousands of years old and is timber for carving, but also for the bows and arrows way back when. So the Irish yew and the European yew is a bigger, different tree. The Pacific yew is a scrub tree. It's under the big giants in the forest. So when the loggers first came through, they didn't want the Pacific yew. They just burned it, actually. It was a waste tree. When it was found to have this amazing drug, they didn't have enough of the trees left. So they quickly had to make a synthetic version. So here's the story. Back in the 1960s, the National Institutes of Health started researching all sorts of plants to find anything interesting. This is why we use ginkgo leaf for cerebrovascular activity, because it came out of that research. No traditional use of the ginkgo leaf for that purpose. Similarly, the Pacific yew had no traditional use in the indigenous peoples. They knew of it, and as many herbs, they might use it for a skin wash, for the skin conditions and things. They didn't really have a big medicine from it. It's not terribly toxic. It's eaten by some of the elk and deer that can, regurgitate and chew the cud and digest and ferment, and they do eat it. The European or Irish yew is deadly poison. It's the yew tree the yew species as a whole is poisonous due to alkaloids called taxines, and the taxines are cardiotoxic and very poisonous, very, very poisonous. But there are also a whole raft of diterpenes called taxanes. So alkaloids are the taxines, they're toxic. Terpenes are the taxanes. There's at least 26 or 27 of them. One of them is Taxol. And it was found in this research in the 1960s, in this screening, and determined to be a cytotoxic. It actually inhibits the replication of cells by messing up with tubulin, which is the cytoskeleton, the protein cytoskeleton that's formed in the cell during mitosis. And then the chromosomes line up on that skeleton of protein strands so that the cell can separate into 2 daughter cells. And what the Taxol does, it stops the protein strands from forming to make the cytoskeleton properly. So the cell doesn't replicate, it dies. It's halfway to replication, and then it gets stopped, and then it'll die. So Taxol is a very, very powerful cytotoxic targeting cells that replicate fast, aka cancer. Very successful drug. However, after a few weeks to months, the cancer cells are quite able to mutate enough to learn to kick that drug out. So you get resistant. So Taxol is very successful. It took almost 30 years to get it from research into drug use. So from the 1960s, when it was identified, it wasn't actually released into general use until the 1990s. And it was found to be a game changer, actually, for a lot of patients, but only for a short time. And many of them then relapsed and had a resistant cancer. And this is where it gets really interesting. In the plant, there are about 25, 26 other related diterpenes, and they act, some of them act, to inhibit multi-drug resistance pumping. That is the capacity of the cell to kick out things it doesn't want. Multi-drug means against many different agents. Resistance pumping because it's pushing against the concentration gradient. So I have ingested chemotherapy in some form or fashion. It's in my tissues. It's trying to get into the cancer cell, and the cancer cell is holding back and saying, no, you can't come in, and get out, and pushing it out, actively using energy to do that. Multi-drug resistance pumping. And some of the diterpenes in the whole herb inhibit that process. So now your Taxol is taken up into the rapidly metabolizing cells, the cancer cells, and can't get out again. So it stays in the target tissue. It's active there, kills the cell. It doesn't have as much collateral damage, other cells getting caught up in the mess, because it's in the target cell. You can use less drugs and get more effective results and more durable results. So when I have a patient coming to my practice taking Taxol, they're going to get Pacific Yew extract to complement the Taxol. Those are positive herb-drug interactions, and it's still a poisonous herb.
I've been experimenting a little bit with the company that was harvesting the material up in Montana. They found that they could sustainably harvest the Pacific Yew tips, and I've been toying with it. So
yes,
it's an interesting plant to.
It's very difficult to find any literature on dosing because yew has a history of toxicity. It doesn't have a history of therapeutic use. So you can't go back to the ancients and say, what did our ancestors, what did the eclectics, they really weren't using this plant. So I have struggled to find any reliable data about dosing. And I have not found it. What I have found is toxicity data, which I've been able to backwards extrapolate to a dose that seemed appropriate. That is a weird way to go about it, but that's all I could really find. And there is a company in Montana that supplies the plant material, but when I went to look at their dosing recommendations, they had massive discrepancies between the herb in capsule versus the herb in tincture. And I ran a lot of math on it and I couldn't figure out. I have landed at a dose, which I have written into my book, but it's a dose based on mathematics, not on historical traditional use.
So more of us need to have some experience with this plant.
Clinical data would be great.
So we can start to get more clinical data.
Exactly.
Now, the one I am familiar with the most is because I met Dr. Jerry McLaughlin, who did the research on it, which is the pawpaw.
And you introduced me to that, so thank you.
Yeah. Well, what's interesting is you talk about using the actual pawpaw fruit, that it actually has some of the acetogenins in it.
It has some, yeah.
Yeah. Actually, what's interesting to me is Dr. McLaughlin did all that research, and I was talking about it at an American Herbalist Guild conference, and someone said, well, how do you use the whole herb? I said, I don't know. All I know is how to use the standardized extract. And this lady at the back of the room, after this had been asked like 3 times, said, if you'll shut off the mic, I'll tell you. And she belonged to a Native American tribe, and they had used pawpaw for generations in the treatment of cancer. And what was interesting is the 3 parts of the plant that they used were the 3 parts that Dr. McLaughlin's research had shown were the highest in acetogenesis. At the time and they harvested them at the time of the year in which they were highest in acetogenesis. I mean, And you're thinking, how did indigenous people know
Mhm.
exactly what part of the
Yeah,
plant to harvest, what time of the year to harvest it, and how to prepare it for
yeah.
to be dosed? And they were the unripe fruit, which they made into
Hmm.
fruit leather, the mature seeds, and the uh, twigs at the full moon right after the spring equinox that were
Well,
pointing upwards, the twigs.
wow. Well, I have two trees growing now in my greenhouse, so we remains to be seen if I can get any fruits off them.
Yeah, it'll be interesting. But
Yeah,
it,
and
but
there's been a bit of a resurgence in the fruit aspect of pawpaw recently. I've seen several posts on my Facebook feed about pawpaw festivals and pawpaw
yeah,
products. But there is some medicine in the fruit. Definitely the seed has the most and maybe has the higher risk because of that. But yes, it's an interesting medicine.
yeah. We have time for just to mention one more. What's another botanical that you feel is really helpful that people should know about?
Well, I live in the Pacific Northwest, and the grandmother tree in our forests, and that's how our First Nations call it, the grandmother tree is the cedar.
Hmm.
And that, I think, is a fascinating medicine. I love using cedar. First of all, it smells amazing. You couldn't possibly overharvest because it's only the spring tips that you're taking, and the trees are huge. But cedar is such an interesting remedy because it has strong action against to inhibit cell replication. It's also a very strong antiviral. So its particular focus is for cancers with a viral origin, which is a lot more cancers than people maybe realize. So we know that, for example, cervical cancer is caused by human papillomavirus, the genital warts virus. But that virus is also responsible, or at least implicated, in most squamous cell carcinomas of the mouth and throat, probably from oral sex practices. But that virus is also found in melanoma and in some lymphomas and in rectal cancers. And so if you can test your tumor tissue for viral load and it comes up positive, then you're going to be choosing cedar as a key cytotoxic herb with specific antiviral action. And that's what I'm always looking for in my formulating, is to get the most different uses specific to this patient with the least herbs so that I can achieve a therapeutic dose and I have more control over how the herbs interact with each other and what I can expect in the body, because the less herbs, it's like if you make soup and you throw everything in the kitchen sink into it, then you don't have it might be nourishing, but it might not taste that good. You want to
Right.
actually, make the flavor profile you're looking for. I often use kitchen analogies in my formulating classes because it lends itself to that. So it's about, having your base ingredients and then making it taste good, or in this case, making it effective for that individual. And that's where cedar would come in, because it has that very particular antiviral quality as well. So,
Great. Well, I would highly recommend your book because it's full of a lot of extremely useful information. So again, the link will be in the description below.
mhm.
And I really appreciate the idea of you call it what, not cooperative,
Collaborative.
collaborative.
Yeah.
Because I remember my best friend's wife got gallbladder cancer, and she decided to go strictly the medical route, even though she didn't want to.
Yeah.
Okay,
Fear based.
fear, because she was afraid her family wouldn't support her if she did that.
Hmm. Hmm.
And what really bothered me is that the oncologist who was working with her told her that if she took any herbs at all while he was under her care, that she would drop her as a patient. So when she
Yeah.
was suffering from severe gastrointestinal upset from the chemotherapy, I could not even get her to drink an ounce of aloe vera or take a little bit of
Yeah.
slippery elm gruel, which would have been a very good complementary
Yeah.
thing to soothe her digestive tract,
Yeah.
totally harmless, non-toxic, etc. And
Yeah.
so we need more collaboration. Love the fact that you brought that out. That's what we need,
Mhm.
is collaboration, so we can work together for the best thing of the patient.
Yeah, and just to close on that note, Stephen, I also think it's not just collaboration with other disciplines, even within our own practice. So, for example, I belong to a couple of study groups, and we get together on a regular basis and compare notes and talk about difficult cases and things I've learned or things I'm struggling with and get input. And so it's also collaboration with your colleagues and peers, and not trying to be all things to all people and have all of the answers all the time. We don't know it all. Of course you don't. So ask your colleagues and peers. And so I really encourage everybody to have a study group. If you're really interested in herbs, then get a little study group going.
Terrific. That's great advice. And thank you for joining me. It's been a wonderful conversation. And it's nice to connect again, because it's been a while since we've been able to work together. All right. Thanks again, and good night, everybody. And again, if you want to get a hold of Chanchal, her links are in the description below, along with the link to her book on cancer.
Hit the like button and subscribe to our channel to catch future episodes of Healthy Conversations. Help us educate others by sharing this video, and please feel free to share your own thoughts, comments, and questions below. To learn more, check out the links below.